Idelalisib is a PI3 kinase inhibitor. It is differentiated, therefore, from the BTK inhibitors or the BCL2 inhibitors. Idelalisib inhibits PI3 kinase, which is one of the proximal signaling molecules in the B cell receptor signaling pathway. In that particular study, idelalisib clearly outperformed rituximab. So it was a combination of idelalisib rituximab versus rituximab alone. And the combination clearly outperformed rituximab monotherapy. So in this particular patient, having been started on rituximab monotherapy might be one place where I would differ from prior management. Had that patient been in my practice at the time, I probably would have gone straight to the combination of idelalisib rituximab. The progression-free survival was about 1.5 years. Overall survival in this very difficult treatment population was, of course, longer than that, but recall that these patients had all had multiple prior cytotoxic regimens. So whether or not they're representative of current patients who are relapse refractory is less clear. My own personal experience with this combination is that it can serve a useful purpose in selected, carefully monitored patients. It's important when starting a patient on a PI3 inhibitor to monitor liver function tests quite closely. The label provides very specific recommendations for the timing to do that because liver function test abnormalities occur primarily within the first 3 months. And once they occur, it's important to interrupt idelalisib and allow the patient to recover. Once they've recovered, it's very rare for those liver function tests to become abnormal again. And so it appears to be a once and done phenomena. However, diarrhea is another consideration, and grade 3 diarrhea in this trial was reported around 16%. It's important to know that even grade 2 diarrhea can be quite symptomatic for patients, and the appropriate intervention is actually to suspend therapy, and important to do so early if a patient has diarrhea. So you need to train a patient to stop idelalisib if they experience diarrhea, even if they haven't been in to be seen, because if there's a delay and they continue their idelalisib until they're waiting to be seen, that can become quite serious. So we also monitor for atypical infections such as cytomegalovirus or PCP. And in many cases, if we can, we try to utilize PCP prophylaxis. We are definitely seeing more and more patients who are experiencing progression after novel agents. So perhaps progression after BTK, progression after BCL2. And what good options remain for those patients? And I think that recognizing idelalisib rituximab as a useful combination can be quite helpful amongst these patients, potentially even utilizing that prior to rituximab venetoclax in some situations where medical comorbidities may make venetoclax more challenging. I think it'll be interesting to see if the non-covalent inhibitors can move forward and restore efficacy of targeting BTK, even amongst patients with prior BTK inhibitor resistance. And we'll be excited to see how cellular therapies evolve in this space, including chimeric antigen receptor T-cell therapy, which is going to be great for those patients young enough and robust enough to get it, but again, in this older population, may be excluded from such strategies. So I hope that you've enjoyed this discussion today. Thank you for your time and have a nice day.